So, hey everyone, thank you for taking your time to join us for the Track 1 workshop, which is on strengthening healthcare in developing countries. Just a quick little admin note. After this workshop, we encourage you all to reconvene on the second floor in our Remo venue, which is just designed specifically for Track 1 teams. And we know that some of you couldn't find your teammates. Just if you have a smaller team than you started out with, I'll encourage you guys to merge with another team's participants. We'll soon circulate a Google form just around for team representatives to sort of fill in who's on their team and what their team name is, just so we're clear who's on which team. And just to all of you, those who are interested, just know that everything will be recorded, and we'll be uploading this as soon as we can on our YouTube channel. So if you'd like to rewatch it, or if you have other teammates that you know are indeed coming, but they just having other time commitments that they can't make it to this workshop that's streaming live right now, then they can always just jump on our YouTube channel and watch that. But without further ado, I'll introduce our two speakers for this workshop. Dina Titkova is the program manager of the Health 10X program at UNSW Founders, which is an innovative collaboration between UNSW and the George Institute for Global Health, which aims to support entrepreneurs, teams, and startup companies that are working to develop products that will improve health outcomes in lower and middle income countries. Vesna Todorovski is the Entrepreneurship and Innovation Program Manager at the George Institute, which is a leading independent global medical research center whose mission is to improve the well-being of underserved communities. Today, they will speak about the work of the George Institute for Global Health and the Health 10X Accelerator Program, which is a joint initiative between the George and the University of New South Wales. They will quickly just touch on how to translate evidence for real-world impacts. So Dina and Vesna, please take it away.
Thank you, Catherine, and nice e-meeting all of you. And it's great to see so many innovators passionate about global health on Saturday afternoon as well. I'll just try to share my screen. Oh, Vesna is, oh, good. So we will be presenting to you today as a team, a program that has been developed in partnership between UNSW Founders and the George Institute for Global Health, which is called Health 10X. And we will basically walk you through the journey of thinking behind why do we need such a program in Australia, and then we'll go into what kind of impact it may have, and maybe it's something for you to consider in the future. So I will pass to Vesna to talk more about the George Institute for Global Health, who basically came up with the whole vision for the program, thanks to their mission of saving millions of lives globally, and their passion of really translating innovations in the real world application. Vesna, over to you.
Thank you, Dina, and thank you, Catherine, for inviting us to be part of this hackathon, and thanks everyone for your time on this Saturday afternoon. What I'll do is speak to you a little bit about the George Institute and our work, particularly around health systems, but it will be more of a broader overview. So I welcome any questions that you may have. Feel free to leave questions in the chat or chime in if you'd like, as we're a bit of a smaller group. So this is just checking that everyone can see my screen. No issues with that or with sound?
Just it's not full screen.
It's not full screen. Okay, thank you. And should be full screen now.
All good.
Great, thanks, Dina. So this is Dina and myself. Thanks, Catherine, for the really lovely introduction. So I'll take you through a little bit about what the George Institute does. As Catherine mentioned, we are a health and medical research institute. We are headquartered in Sydney. We're about 20 years, actually we're just over 20 years old. And our remit has been from day one to generate research and evidence that specifically looks at the largest disease burdens and health burdens around the world. And so you can see here our mission is quite straightforward: to improve the health of millions of people worldwide. So the Institute at a glance, we are global both in our name and what we do, but also where we are located. As I mentioned, our head office is in Sydney, but we also have offices in India, Delhi and Hyderabad, an office in Beijing, and we also have an office in the UK, in Oxford, in the city of Oxford, and shortly to move to London. So having offices in these countries that we work in, it gives us a unique advantage in that it places us within a network of research, but also within the local healthcare system. And this allows us to undertake research directly with community, and I'll speak a little bit more about that shortly. So as I mentioned, our focus is the biggest health burdens in the world, and I'm sure you're aware of some of them. The top causes of death globally do not really change year to year. Even in the middle of a pandemic, they won't really change, and they are all non-communicable or chronic disease. Not all, but the top causes. So for example, heart disease, stroke, you'll see in the top 3 of causes of death around the world. So they're not even region specific. And that is very much our focus at the George. We look at non-communicable and chronic disease, but also injury. Injury and trauma is one of the generally the top 10, top 12 causes of disease worldwide. But what sets us apart from many other medical research institutes is that we do focus on low resource settings and emerging markets and populations that do bear the brunt, the greatest burden of a lot of these diseases and health challenges. And when I say that, people tend to think of countries like India, for example, or regions like Africa, but we don't only focus on emerging markets and underserved populations globally. We focus on these populations closer to home as well. And I'll go into that a little bit more shortly, but it includes, for example, working with Aboriginal and Torres Strait Islander communities to improve health outcomes for them as well. We have a number of research divisions or themes at the George, but they are all focused on the 2 areas, NCD or injury. And so this includes anything from food research and food policy to critical care research, to respiratory, which is very timely at the moment with COVID, and also neurological and mental health, as well as cardiovascular being such a broad disease area. We have a lot of expertise at the George in clinical trials, but also increasingly more in policy and advocacy. But what we do quite well is that translational research. So we generate evidence and then look for ways to achieve the greatest impact in the community from that evidence base. Oh. And just very briefly to show you that we are truly global in scope. This is a map of all of our work, as well as where we are located. The purple locations denote where we have offices, as I mentioned before, and the green locations denote where our clinical arm sits. So the George is a little different to other research institutes in that we have an in-house commercial arm. The institute itself is a not-for-profit research institute, but our commercial arm is very much focused on taking these evidence-based innovations and taking them to market. And we also manage clinical trials through this arm. We do that for research initiated by the George, but also externally. So that can include clinical trials run for pharma, for example. So all of the green that you see on this map denotes those clinical and commercial networks that we have. So we have quite a broad reach and very much global in our focus as well as our work. So as I mentioned, we very much focus on NCDI. So again, that's non-communicable disease and injury. And the reason that we do this is because the burden of this is so broad. And I'm sure some of you are aware of these numbers. Some of you may have a focus on this as part of your study. So I won't go through all of these numbers, but this is just to give you an overview of how large that burden is. And we tend to think, especially this year with COVID being such a focus, that infectious diseases are the top killers, and they certainly are by no means to be taken lightly. We still have many deaths globally each year from malaria and tuberculosis and HIV. So they're still very serious and significant problems. But you can see that in the the graph table there, and this is via the World Bank, that non-communicable diseases vastly outnumber communicable diseases in both high-income countries, but also emerging markets. As populations become older in emerging markets, as well as globally, the population is aging, but we see as economies become stronger and therefore healthier, their populations age. And so this brings new health challenges. Where a country with a younger population and perhaps not as developed and not as a developed economy may have previously faced much more burden from infectious disease, as their economy is bolstered and they become what we call an emerging market or more of a developed country, their population ages, and then that's via healthier living, better healthcare systems, preventative measures, etc. It brings new challenges, and many of them are lifestyle or preventable diseases. So where the challenge would previously have been infectious diseases like malaria or TB, we see that in these countries that are becoming emerging economies or stronger economies, the disease burden and profile is more similar to a country like Australia, where the top causes of death will be heart disease, stroke, cancer, for example. So it's becoming sort of a bit more homogenous around the world in some of these countries. And that's a big challenge, because the healthcare system is not uniform globally, as we're all aware. Every country has its own challenges and opportunities with healthcare systems. And so there is a challenge in a lot of these countries and markets that they don't have the healthcare expenditure to tackle these burdens of disease. So that's what this particular table looks at. And in this we saw, so we have the challenge of NCDI, and then we have emerging markets that need stronger healthcare systems and are facing more of this burden. And some of them do have more of a budget increasingly to spend on healthcare, but there is an opportunity to innovate for health solutions within these countries. So we know that Western markets, and I use Western to denote developed economies like Australia and the US, health innovation is a big market. There is a strong commercial opportunity, but more and more there is an opportunity in markets like India, where as the population is aging and the economy is growing, there's a larger middle class who are able and willing to pay for better healthcare. Going back a little bit to what we do at the George, because our focus has always been the global health burdens, but also a way that we can tackle them that is affordable for the people who we are trying to help. Social entrepreneurship has always been at the heart of what we do, although as a phrase, it's not something that we used until recent years. And so the model I've spoken about, where we have the global health focus and look for the commercial opportunity, lets us create social enterprises. And we do that a lot via work with community. And I'll go through some examples that we have here, but also I welcome you in your time to look at the George Institute's website, and also reach out if you have any questions about some of the work that we do. For example, I mentioned earlier our Aboriginal and Torres Strait Islander health program, and it's been extremely successful, this particular program. It's been a formalized program for about 5 or 6 years now, and it works across all of our research themes and divisions. So it's not focused on any particular health area, but rather strengthens any Indigenous health research that the George is undertaking. And from the outset, that program has really advocated for community and what we call consumer, but in Indigenous health we refer to it as community involvement. And it's so vital for health research to involve, whether you want to call them consumers or patients, but essentially the population that you'll be working with and looking to innovate for. You can't do this sort of work without involving them and consulting them, because you need to consult with community and populations to really determine what the unmet need is, and then also ensure that you're working for them and with them, rather than sort of imposing what you think is a health innovation or health solution for them. And it's particularly important to do this for underserved communities. And here in Australia, when we work with Indigenous communities, it's the key element of research, because it means that we are able to work with a community that will trust us, and also strengthen our research and be involved in the research as well. And so with our Aboriginal and Torres Strait Islander health program, we've had several key studies looking at burns and burns in children. And so we've had to involve, but also really needed to involve from the outset community organisations and community healthcare workers, so that we could have access to consumers and patients, be able to work with them, to include them in this research, and then also to include them in the outcomes of the research, so that they are able to have their input at every step of the research. In terms of what we're doing around health, social entrepreneurship and health innovation, we have now a formal and more structured program around this work for the last few years, although prior to that it was just something that was a little organic at the George. It's now become a bit more structured, and the examples I've included here give you an idea of the sort of work that we've been involved in. The very first tile is a gentleman named Vince Garvey, and he designed an affordable dialysis system that is currently going to clinical trial. And the idea is that this system will be, once it's ready to launch to market, will cost around $10,000 per unit, and will be something that regional healthcare clinics, smaller hospitals in isolated areas, or even in impoverished areas, can have access to make dialysis much more affordable for people who would otherwise die because they can't afford this treatment, or they can't get to, if they're in a regional area, they can't get to the place of treatment. The second tile you see here, it's an iPad screen, and this is another example of social entrepreneurship at the George, where community and consumer involvement has been driving the work all along. And this is our Smart Health program. So Smart Health uses clinical evidence, it uses research evidence to drive clinical decisions. So it's a support tool for healthcare workers and doctors, designed specifically for healthcare workers in regional settings, again, and also in underserved settings. So, for example, a village may not have a doctor, but healthcare workers are able to use Smart Health to guide their decision-making and diagnosis of certain health conditions. And this one is used around Asia Pacific, but also it's continually improved via the input of the healthcare workers and being involved in updated research. The third tile along represents Food Switch, which is an app that we developed at the George almost 10 years ago now. And it's a behavioural change app at its core. When you're grocery shopping, you scan a barcode with the app, and it will suggest to you alternative products that are healthier. So whether that is products that have lower salt or lower fat, for example, or if you're eating for a specific diet, you can tailor the app to, for example, lower blood pressure. You can tailor the selection that way. And the final tile represents our polypill, which is one of our newest commercial products that will go to market shortly, and it's been through years of clinical trials. And so again, this will be an affordable combination dose pill targeted for blood pressure. So that's an overview of work at the George. I welcome any questions that you may have. I can't see the chat screen at the moment. So if there are any questions, please let me know. But hopefully this has given you an idea of what we do and why we do it. And the work that we do prompted us to reach out to UNSW to create a program that really captured and acted as a catalyst for health innovation work. So I'll pass on to Dina, who will take us through that program now. Thanks, Dina.
Thank you, Vesna. Would you mind if I share screen? Or?
Yeah, absolutely.
I'll share the screen and just continue. Oh. Should be all good now. So what Vesna gave is a very extensive introduction of why we need to work on the challenges of chronic diseases and why it's so particularly important to address those challenges in underserved populations. And basically what I will talk to you about is one of the platforms that we jointly created, which is called Health 10X program, that helps innovators like yourself to take your idea to the market, basically to take your idea to underserved populations. And our big vision is really to foster the development of social enterprises at scale. We're quite a young program, but we really hope to support more and more innovators each year to foster creating affordable solutions or solutions that make healthcare accessible in low-cost settings as well. And of course, the need for this program was very straightforward, as Vesna was talking about. We really need to think about those global health challenges ahead, mainly chronic diseases. Majority and bulk of investment so far went into infectious diseases, but this balance is changing. COVID maybe made someone think that we need to pay attention more to infectious diseases, but statistics is still the same. It is chronic diseases that kill most of the population. And of course, we are driven by the vision of transforming lives of people in underserved populations by supporting our social enterprises. So this is a very big and fancy goal, but as you would learn this weekend, and I think Catherine told us that you already had a few workshops, it actually all starts from very simple exercise. It all starts with design thinking, with rapid prototyping, and thinking and trying to understand what do the end users need and want. So all the tools that you will be learning through this weekend are fundamental for you to create an innovation that will be applied in the real world settings. And whenever you come in which accelerator program, these tools will be with you. So I will encourage you to really lean in and take advantage of all the training. Because once you master the tool of design thinking and creating solutions with end user in mind, your journey can be very exciting. So for example, if you would come to us with your solution, we will take you through a Health 10X program. And at this point, once you have already a prototype or MVP of your solution, you will be provided with a set of education, both on what we call business modules or business side of things, and health commercialization modules, such an important topics as health economics, clinical trials, regulatory requirements, and IP management. So all this comprehensive learning is here for you, accessible. This program is open nationwide. This year, no surprise, it's being delivered online. So we had participants from all over Australia, and we welcome more and more people to come. We do hope to see you in the program next year. And just to give you a bit of a picture of, at the end of the journey, what can it be? What kind of companies come outside of the program, and what is their vision of in terms of changing the world? If we look at the first team, it's a beautiful team called 4 Eyes. The founder and the inventor, Dr. Sarah Crowe, she's an ophthalmologist herself. She was doing some volunteering work in developing countries year after year. And she was just frustrated to see that a lot of people go blind just because they were not provided glasses on time. So something that we in living in metropolitan areas have easy access to, we just go to optometrist around the corner, check our eye vision, come back in 1 week and we get our glasses. This is a luxury in developing world. And what's happening that those checkups never take place, or even if they do, people cannot travel to pick up their prescription glasses. So Sarah decided that she really wants to change it. That was around 4 or 5 years ago. And she started prototyping in her garage, not a specific lab or fancy equipment. She started playing with different parts of the device to make sure she is creating a testing wheel that will allow even untrained healthcare professional, for example, community worker, to go into remote communities, test eye vision, and then she created a way on how you can immediately dispense prescription glasses at the point of care. So this is a revolutionary thing, because what it will do for remote communities, and it was trialed already in Papua New Guinea and in Fiji, it will prevent blindness that is affecting over 1 billion people worldwide. So we will be now working with Sarah and the team on trying to help them to set up the business side of things, marketing channel, understanding the right customer groups and so forth. But just an example of a really passionate individual who saw the need in underserved population, worked on the problem with passion, and now is very close to bringing this to the market. Another beautiful team, and this will be relevant to, even more relevant to all of you, that's a group of students. So a beautiful group of students from Bangladesh just were frustrated with the way healthcare access is provided in, and they are from Dhaka in Bangladesh. They've been frustrated to see that you need to call and wait for 2 hours on the phone to get an appointment. And if you come to the clinic, you need to wait 2-3 hours for a doctor to see you. And sometimes you cannot even see the doctor because maybe it was booked with someone else. So they just set up and decided it should not be this way. We do have technologies, we know how it will work. And of course, by living in Australia and studying in Sydney, there's another examples. So they formed a team, and in the last 6 months, it was a very accelerated journey for them. They got some traction with hospitals in Dhaka. They are getting some interest from NGOs based in Dhaka as well. And as of a few weeks back, we actually took them into Accelerator Program 2020 to further support them, because their passion and understanding of how they really want to make a difference in their home country were just outstanding. So we hope in 2, 3, 4 months, we'll be making more news with the team. So students like yourself. And that's just 2 highlights from this year. We did have a very big cohort. We had over 45 teams who started the program and over 30 who basically finished the pre-accelerator, and selected 5 high growth teams into accelerator program as well, which shows a scale, diversity, and that we do encourage everyone to come and receive support that is being provided there for all of you. Last year, we worked with another cohort, and just to give you a sense of what the team innovated last year, Team Biko House is one co-founder is based in Malaysia, another co-founder based in Sydney, and they've been frustrated with the way that pressure ulcers in bedridden patients are treated. And the thing behind this is that there are no affordable technology to prevent pressure ulcers. It's either very expensive mattresses that no one can afford in underserved populations, or you will require a nurse who will turn the patient every 2 hours. So they are about to start clinical trial. COVID changed their plans a bit, but they're going strong. AtoQuest, it's a research-based innovation aiming to revolutionize the way tuberculosis is being diagnosed in developing countries. Cardiobionic aims to bring 10 times down the price for heart assist technologies. Just for your reference, the need came from a cardiac surgeon in India who basically saw his patients dying each year because they could not afford heart assist technology or heart pump. The cost of a traditional heart pump is around $100,000, which is for average Indian, of course, something unaffordable. So they 5 years ago, they set up a task for themselves to bring this cost down 10 times. So this heart assist technology will be $10,000. So they will be running, they need to run clinical trials because of course it's implantable device, but the technology works in the lab settings, and the passion of the founders made it possible to happen. Biosense Tech, and it's again low-cost way to diagnose pre-diabetes by testing for insulin in saliva. Can be used in low-cost settings as a great predictor of the onset of diabetes. And then evidently team, it's the only software team that we had. It's the power of collecting and analyzing data to help doctors to take the right decision at the right point of time. And with this, I would love to say good luck for the hackathon. Enjoy your time. I hope it will be fun. I hope everyone will enjoy, because it's an important part of a weekend's hackathon, so it should be fun. On our behalf, we will be happy to answer your questions this week or in a few months' time if you're really committed to coming up with solutions that address global health challenges, can be applied in underserved populations. We would love to hear from you. We are here in Australia to support all innovators who have this vision in mind. So please don't hesitate to contact us with any questions. And that's all from us, unless anyone has any questions. Please feel free to jump and just ask. Catherine, how is the day looks today?
Sorry?
How is the day looks today? What's the plan for the day?
Oh, okay. Yeah, so we just had our workshop with IBM on design thinking earlier this morning. After this track workshop is done, we'll have a 2-hour teamwork time block. So Vesna will be free to jump on to floor 2 of the Remo venue, and just to come around to help teams on their tables. If any of you want Vesna to answer any questions, just remember to ping her on using the chat function in Remo, and that should be fine. Just a reminder that with some of the teams that have gotten a bit smaller, if you'd like, feel free just to jump back onto floor 2 and see if there are any smaller teams that you guys can join forces and make a bigger, better team. But yeah, thank you so much to Dina and Vesna for giving us that talk. That was incredibly insightful. Hopefully you guys have gotten some really great ideas out of that talk. So any Q&As, just please message Vesna or Dina. I'm sure we'll be more than happy to help you guys out. And with that, we can move back to Remo. So see you guys there.
Thanks, Catherine.
Good luck, everyone.
Good luck, everyone.
Enjoy.